Good evening, everybody. My name, like Mr. Johnson said before, as well as Commissioner Richards, my name is Tariq B. Darrow. I am the saliva testing coordinator for the Molecular Diagnostic Lab. My sole responsibility is to work alongside the Ministry of Health as well as MDL to help facilitate saliva testing throughout the country, within the community, as well as taking on the task of logistically sorting out saliva testing throughout the school system. And the objective of us going into the school system, both public and private, is for us to start screening students and staff so that we can have another safety measure in place so that we can work on keeping schools open as long as possible. So I'm just going to click to the next slide. So, like I said, the objective of this screening is we are screening the school population in a 4 week period. And in this 4 week period, we are going to help identify if there's anyone who may have the SARS-CoV-2 virus, sorry, also known as COVID-19. This screening tool also helps health officials properly identify persons who may be asymptomatic or have been undetected within the community that may have the virus. It also helps, like before, helps health officials to swiftly identify exposure risk of staff as well as students and keep and follow the proper protocols so we can isolate those individuals that have tested positive. I know in the past when we have had positive cases in schools, it was a broad brush where what will happen is the entire school was shut down. With this screening tool on a weekly basis in a 4 week time period, we will be able to quickly identify those small pockets of exposures and help identify and try to keep schools as long as possible. So the goal of this program right now that we're initiating into the school system, both public and private, is to try to prevent a lot of the stop and start that we've had this school year, actually since last year as well. Many people have participated in the saliva screening process. But for those who haven't, I'm just going to basically go over the layout of how the screening process takes place. So anyone who participates in the saliva PCR test screening process should not eat, drink, chew gum, or smoke at least 30 minutes before, as well as someone brought up brush their teeth. One of the reasons why is because this can contaminate the sample and you won't be able to get an accurate reading and having to give you a call to say that you may have to retest. The process involves spitting saliva into a tube that is provided by the Ministry of Health, and all samples are sent to the lab and run through our PCR machine to test for the virus. Most results, if it is a most results return within 24 hours. If the person is negative, they will be emailed. If it is positive, other steps will be taking place with your doctor getting the notification, even though they do get the notification that you have a negative test result, but they also get the positive. And the Ministry of Health officials, ESU team, will step in and you will follow the next steps from the Ministry of Health. Most people, we do get our tests within 24 hours. However, if there's a large amount of tests coming into the lab, the time frame can be a little bit longer than normal. In previous town halls and meetings we've had about this subject, is that if you have not received your test results, say after 48 hours, please call the COVID hotline, check with the MDL lab, because there may be an issue with your email address. And when you call, and if there is, we can update the email address and send your results right away. Key thing to note, if you test positive for this screening, the saliva screening, you will be asked to test with a nasopharyngeal test that will be scheduled by the Ministry of Health to confirm that positive screening. Later on, there will be questions around this, and Dr. Weldon will be able to jump in and explain the science behind the reason why we do this. But at the end, I will open the floor up to questions for everybody. So this is what we're asking of schools as well as the parents. So this is what it will be, how it will be laid out. So we're looking at testing 25% of the student population each week. So we're not looking at just testing one class each week. We're looking at testing 25% of each year group or each class each week, which gives you an average of 25% of the entire school population. So school administrators and principals who we have met already with um, will be given the task of proportionating their schools into 25%. Because the reason why we ask them to do is because we don't know the school population, and every school is different in size. A preschool maybe is smaller than, say, a senior school like Cedar Bridge. So, an example of what it may look like based off of what your school may provide is that where week one, students with the last name A to F will be tested. So any student that falls in that category in your school will be tested. And week two, week three, week four, depending on how the school decides to proportionate their school by their 25%. Every list for who's getting tested will be sent to the lab so we know which students will be tested each week. We have an option where the teachers and the staff in the school have to be tested. And with this, we have sent off a template to the Ministry of Education where the teachers will have to be placed in risk categories depending on how they move throughout the school. And on another slide after this, I actually will show you what that template looks like. So we have three categories. We have the high risk, the medium risk, and the low risk. And I'll go into more details when I look at the next slide. But based on, depending on how high of a risk you are, is depending on how many bubbles you interact with and how you move out throughout the school. And I'll just go into a little bit more details when I go to the next slide. At every school, when we do the testing, there will be a designated area or a designated room. I know at the moment we have started with the private schools, and some schools actually have a set up pop up testing site set up on the outside of their school. And in previous, before the Easter break, the schools that we worked with actually set up their a school assembly hall for testing for that particular time. The principals and the administrators, as well as you, will know the days that testing will take place. So, if and I actually have a mock schedule that will come up later on. So if your child attends Purvis, there will be a specific day every week that Purvis will be tested. Your child may not be tested that day because they may not be part of that 25%. But that it'll be one day a week that just your child's school will be tested. And that day will remain until the end of the school year. For the parents who are concerned that may have children with special needs, so children who fall under the spectrum, so ASD or the autism spectrum disorder, or children who belong in functional skills classrooms. We have actually worked out a plan to properly test them on a weekly basis as well. That's slightly separate from the saliva testing because, as many of you know, they have deficits that will hinder them spitting saliva into a tube. Actually going to be getting a list from the Ministry of Education on how many students that fall into that category, and the schools will identify them for the teams. So the team and the teams go out, they will be testing them using a different method from the rest of the school body. As I said before about the risk levels for teachers and staff within the school system. So, and you look at this slide right here. This template was given to the Ministry of Education, and they will have each school has this template. So when we talk about high risk, we're talking about anyone who's in the high risk category will be tested once per week, and all staff that move through multiple bubbles throughout the school day. So it may be the principal that interacts with the reading teacher, who interacts with P4s, who also interacts with P5s, and has conversations with the PE teacher. The PE teacher will also be considered high risk because they have to deal with the entire school population. A high risk group are those specialist teachers that move in and out of primary schools because many primary schools share art teachers and share music teachers. And the reason why we consider them high risk, because if they are positive or they interact with someone who is positive, they can be a potential super spreader of the virus because they're moving from one location to the next. And these positions in schools are crucial so we can't cut them out of schools at all. Now we look at the medium risk. Medium risk staff will be tested every 14 days. All staff that are that are in this medium risk category, they basically interact with probably one or two bubbles throughout the school week. They don't move as much through the school, but they are not maintained in one area or one bubble. And also, student staff that are fully immunized, meaning had the second vaccination plus the 2 week window afterwards, will be considered under medium risk, and they'll be tested every 14 days. And staff that fell under the high risk category that are fully immunized will actually move to the medium risk category. So they'll be tested every 14 days. And low risk may be that classroom teacher or that staff member in the school that only interacts with either one bubble or doesn't interact with anyone through the day. So, such as you may have a custodian in your school that doesn't interact with or teach through the day. Their main responsibility is just to make sure that the school is tidy and clean. So they may be tested every 30 days. So the risk assessment of how we're looking at the staff within the school to make sure that the staff are safe as well as the students. All students will be tested once per month, but they will fall in however the school proportionates their 25%. So child A in say a teacher Ms. Lightbourne's class may be tested week one, but child B may not be tested to week three because that child B falls under the 25% that shows in week three. Give you a quick diagram of what it actually would look like within a school, like what it looks like in a school. So if you look at classroom 1, 2, 3, 4, and 5, so it's just giving me a demonstration of say it's 12 kids and we proportion it for 25%. So if you look at the light blue, every child that's in the light blue will be tested week one. So we're pulling from each class, 25% from each class on a weekly basis of which students will be tested. If you look at the center of the diagram, we have a red square, and that's to demonstrate that high-risk staff or that high-risk teacher that interacts with every single class throughout the school day or multiple class, as such as like the yellow square, where that teacher or staff member interacts with probably one or two different bubbles. So this is just a visual of what it actually looks like with the plan, or what we mean when we're saying 25% or high risk, of how the staff and students move throughout the school day. As I said earlier, we actually created a testing schedule for the entire school system, and we're talking about both public and private school. So this is an example of what it may look like, but once we finalize all the details with the ministry and the various different public schools, everyone will get a schedule of when testing will take place at the various schools. So our goal is for the Saliva testing teams to go out and test literally 44 different schools in a week. So as you can see on this schedule, you have what we try to do is to group the public schools by regions. So they may not be on a Monday, it may not be a Friday, but just know that what to make it easier for the testing teams to get in and out of schools is that we're going to be grouping a lot of the public schools by regions. So if you look at Monday morning, we have all the St. David schools together. So it's quickly for the teams to rush, get to these schools and administer the test as fast as possible, in and out. And we're looking at working in an hour and a half windows per school. And I mean that is because, like St. David's preschool, for instance, it may have, say, 20 children that go to St. David's preschool. And in St. David's preschool, 25% of those 20 kids is only 5 children. So literally, it might take us probably 20 minutes to test that 25% that day. But then you look at a school like Cedar Bridge that may have 600. 25% of that 600, not including staff, is 150 students. Actually give ourselves a little cushion to work with, depending on the size of the school. So everyone has the same proportional amount of time. And also, whoever goes to your student's school, the staff, they actually will be, they'll actually they call the school beforehand to let them know what time it's starting, and the administrator or principal on duty will be there to make sure that everything is running smooth because they know the students and they will be able to determine who's being tested and who's not being tested. And what I forgot to say in the beginning, the only children being tested in this saliva testing program are the children that have been given parental consent. If a child has not been given consent, they will not be able to be tested. And I know Commissioner Richards is working on a consent form that's going to be going out to all parents pretty soon so we can start the testing at all the public schools on the island. So here are some frequently asked questions, and I'm just going to leave this up, and I'm probably going to ask Mrs. Johnson just to quickly go through the question and answers real quick with everyone, like we did at previous, so we can just get through it. But these questions are some of the questions that constantly reoccur when we have these discussions, whether it be with parents, whether it be with other stakeholders in the Ministry of Education, as well as private school principals and administrators. So I'm just going to get Mr. Johnson to just quickly, briefly go through this so we can move on and open the floor to questions to everyone. And Dr. Weldon is on board to answer any questions in relation to the science side of it.
Great, thank you, Mr. Bean Darrell. So the FAQs, we've had questions about alternative tests available that people can take before they enter the school and get faster results. The answer is yes, there are rapid antigen tests. In Bermuda, they do, although they give a rapid response for those that are very infectious, they miss a lot of samples with the CB value above 30. And that's the reason why they're not using those other tests, because then there's little risk entering the school system. Accuracy of the saliva PCR test is the same they found as a nasopharyngeal test from the lab's perspective. The exact same procedure is done in the lab, but the saliva test is less invasive and easier for those being tested. Why do we need to take the nasopharyngeal PCR if the saliva test is accurate? The testing committee in Bermuda has not approved saliva testing to be a diagnostic test. So it's not an official diagnostic test in Bermuda or according to the Pan American Health Organization. So what they do is they confirm the saliva positive with a nasopharyngeal positive for it to be recognized nationally and internationally. But they're finding a direct correspondence with positive results in both the tests. What happens if a member of staff or student tests positive and they've already been at school? I think Mr. Bean Darrell, they've already explained that. The Ministry of Health will be informed immediately by Dr. Weldon with the result, the school and year level. The Health Ministry will then contact the case and at the same time contact the Ministry of Education, which will then notify the school. With private schools, the Ministry of Health will notify them directly. The goal is not to have a delay in the positive individual finding out and the school being notified. Will school principals or administrators be informed of test results? No, they will not be informed of any individual results. MDL will provide a weekly summary of the weekly testing performed so they can be kept for school records so that everybody involved is aware of what happened during that week. Can parents and children opt to be tested at one of the government testing sites? Yes. The goal is to make sure the school system is safe and those inside the system are screened as much as possible. It is important that the testing site is made aware that they are testing for school screening so the lab knows and they will not be tested again at school. I'd like to go to the questions that were actually submitted in advance before we go to the questions that you might have come up with during the presentation. Somebody did ask how often the kids will be tested. That's already been answered during the presentation. If COVID tests are not mandatory for students and teachers before returning to school, how will schools be able to mitigate their risk of exposure?
So, Mr. Johnson, I can certainly respond to that question, and we appreciate the question coming in. What I would underscore with everyone is that schools have safety and health protocols that were developed by the Department of Health. They have asked for schools to adhere strictly to those protocols and procedures while staff and students are in the building. Those protocols have many layers or safety layers for staff and students, and so therefore, they can help mitigate the risk of exposure when those protocols are adhered to strictly. So that's something that the Department of Health is emphasized even more so as school staff and students returned on the 10th of May.
Okay, another question is, if there is not a substantial amount of signed consent forms, will you then enforce testing?
So at this juncture, the position is that we are focusing on students and staff who give consent. Once we get through the next, I guess to the end of term, we will reevaluate and our position. We would seek legal advice around that as well before any changes are made.
This is actually not the first time this issue has come up. I'm curious as to why parents might not consent to this testing, but maybe we can discuss that later. If testing is needing to be conducted on such a regular basis, why are you opening schools at this time?
Dr. Weldon, are you able to assist us with that? Oh, Dr. Weldon said she cannot unmute, Mr.
Oh, I'm
Johnson.
sorry. I got. Sorry. Where is she? Oh, there she is.
Thank you so much. Good afternoon, everyone. Happy to answer that question. So the reason why we're adding this layer onto the school safety protocols is not because we don't think it's safe to open. We have those specific measures in order for us to move from phase 1 to phase 2. The reason why we're adding the testing is just so we have that added reassurance that nothing is going on. This is a very similar screening process that is used amongst other populations in the community that we consider vulnerable, so including the rest home residents and staff, as well as BHB staff. They actually get tested once a month for BHB staff, and then for rest homes, actually at the moment it's every 2 weeks, and we'll fall back to once a month how it was when things were kind of died down. We actually started testing rest homes, for example, last September, and we didn't have a positive for months. But what it did allow us to do was we were able, when we had the last outbreak, to catch any positive staff before they were potentially able to pass it on. And so in a similar way, we are trying to do this to kind of have our guards up, looking in every direction, as it were, for the virus, so that if it does enter, we can act on it more quickly and prevent the widespread that we witnessed in this last outbreak in our schools. So we believe it's safe, as with the Ministry of Health, working with the Department of Education to make the decision to open yesterday, but we want to make sure it continues to stay safe. And that's the reason why we're doing this screening.
Thank you very much. And another question here is, I think we got this. Sorry, I'm looking at the wrong. Just 1 minute, please. What is a plan of action for parents that do not wish for their children to return at this time, Mrs. Richards? Will learning via online class, camera, or other means be available for at-home children to connect?
Thank you for that question. It's a very serious question in terms of a parent making a decision for his or her child not to return to school. I don't want to be, overbearing, but the Education Act requires our students to be in school. If students are not going to be in school, it's because they are unwell, and there should be a medical certificate or medical note from a doctor. Once that is provided, we consider there are a couple of categories. One, we have students who are considered extremely clinically vulnerable. Those students have, in most cases, been out of school for the bulk of the school year. And students who are extremely clinically vulnerable receive remote learning services. So they can actually tap into the classes through remote learning. If a student is out and we have a doctor's certificate and that student's out for a short period of time and he or she is able to do work and to do tasks, then learning tasks or learning packets are provided. Those tasks can be provided via email, or some schools use Class Dojo, Schoology, etc. But for students who are not extremely clinically vulnerable, they do not have remote learning access. So a parent who's saying, I'm not sending my child to school, that parent really has to make some decisions around whether the student is going to remain enrolled in the school or not. But the school is not required or obligated to provide work for a parent who just says, I'm not having my child return to school. So I just wanted to make that clear. So if there's a doctor's certificate for extremely clinically vulnerable or a student who is unwell for short periods of time, it's either the remote learning or their learning tasks or packets.
Okay. Will my child be allowed into school if I decline the test?
So the tests, in order for the students to participate in the saliva testing program, it requires parent consent. And so a student whose parent has not consented will not participate in the saliva testing program, but that student does attend school. So the consent is for the saliva testing program. The consent is not for whether or not a student attends, can attend school.
And then another question here I think has been answered, but I'll voice it anyway. Is the saliva test going to be the spit test or swab of the mouth? If a child does not get the test weekly, is that going to impact their ability to be in school? And how is social distances going to be applied if the classes are so big, mixing of classes? So it is a spit test and not a swab test, correct? Mr. Bean Darrell?
Dr. Weldon said she cannot unmute again.
Oh, how is that? Unbelievable.
Sorry. So the test is for the majority going to be the spit test. This is the same test that we utilized towards the beginning of this current outbreak when school was still in. What we found is that all age ranges were actually able, from the lower primary level all the way up to senior school, to do the test. And so that will be what we do employ, but we are cognizant of the fact that there are some students that cannot salivate, and as much as they try for 15-20 minutes, nothing is coming out. We don't want to skip them, and so we will be getting the buccal swab, which is just a mouth swab. It's not the one that goes to the back of the throat, it's just on their cheeks, and that will be something that we get from the Ministry of Health specifically for the ASD students, that would allow them to still get their test. So majority will be the spit test. It's about 1 mil. Takes about a minute, as Tariq said. And then the ones that cannot salivate will get the swab, the buccal swab.
Great, thank you. Mrs. Richards, do you want to answer the one about social distancing?
Can you repeat the question?
Somebody concerned about large class sizes and mixing of classes. How do we manage social?
For the most part, the class sizes have remained fairly constant since the school opened. They opened under the protocols and guidance of the Department of Health, who actually went on site to look at the layout of classrooms. If there was a query or concern about the number of desks or how they were organized, we had a representative go out. And so the classrooms and the way they're set up would be, they would be set up to meet the protocols set out by the Department of Health. So was a second part to that, Mr. Johnson.
No, they're just concerned about the size of the classes. Some classes are very big, she says. And yeah, that's it. I think you've got it. Next question is, my child is in P1 and I do not expect him to self-administer his saliva test. Will his teacher or assigned teacher be conducting it to be sure it's done properly?
Can you unmute Dr. Weldon? She's mute. Can you keep her on, or Mr. Bean Darrell? They're both. Can you unmute them?
I'm sorry.
I can answer that. Within the next 4 weeks that we're going to be testing, basically it'll be about 4 or 5 weeks. The child will not be testing on their own. We will actually have the saliva teams there, working with the children to get tested. So the child won't be doing it on their own.
Great. There's another part to that question. Well, a different question. What days will the test be conducted? This person is suggesting Fridays, so that all results are received in a timely manner for the new school week ahead.
So that is something that we've been doing actually with I think it's the camps for the essential workers. We're testing them on Friday to clear them for the following week. The issue logistically is we're talking about between public and private over 10,000 people. So there's no way, as best we can try, to test all those people on that day or even between Friday and Saturday. So the idea is to spread it throughout the week. It will mean that some schools get tested on a Monday and get results, should be by the following morning. It's just a logistical issue. If we had the ability to test 10,000 in one day, we would have done that. But at this time, we're not able to. So there will be some schools that actually do tests on the Friday, but not all of them.
Have all teachers been vaccinated?
We appreciate that question, but we're really not in a position to share that data. It's considered personal medical data. The other piece is, I believe, when teaching staff on the island signed up for testing as well, that the Department of Health did not make distinctions between public, private, or Bermuda College. So we don't have that data, but we're not in a position to share that data. We would not share that data because it's considered private.
There's somebody here saying they feel it's too early to reopen. They should have finished the year on remote learning because it's been going great and they're happy with how it's been run and there's no issues keeping them safe at home. Can you talk a bit about the preference for in-person learning so that everybody understands what the position?
Thank you, Mr. Johnson. Two things there. The question is run, or the statement, it's too early. The parent is pleased with remote learning, and I'm glad that the parent was or is pleased with remote learning. However, we recognize and we support the research and evidence that indicates that in-person learning is the best environment for children to actually be in the school, engaging in person, interacting, and taking advantage of all of the other things that are offered within the school. The question around why did the schools open, I just want to remind parents that the Department of Education takes its guidance from the Department of Health, who would have evaluated the evidence and the data and made a determination that schools could reopen.
Great. And another question, Dr. Weldon, about the cycles of testing. What cycle threshold will the children be tested at? I think she's talking about the nasopharyngeal test.
Yes, so actually the PCR testing for both nasopharyngeal and saliva is the exact same. It's just as a different sample type, and the saliva being less invasive. As far as how many cycles, the cycle threshold question is actually a two-part question. The first question is, what are the total amount of cycles? We follow what the recommendation is from the manufacturer, because that is what was approved to make it a authorized test. So the test that we're doing uses 45 total cycles. It then becomes the countries of choice, their prerogative, as it were, to determine what is the cutoff. And so Bermuda has followed Public Health England's guidance from the UK to say that any sample that has a CP value of 40 and above is not going to be considered positive. If it's between 37 and 40, we actually retest that sample to make sure that it is a true positive. So when I see a positive result, which I get 16 hours a day, well, hopefully not all positives, but if I get a positive result, I would then say if it's between 37 and 40, to the lab, retest that sample. If it comes back again as positive, then I will report that to the Ministry of Health. Before that moment, it is not recorded as positive. So in a nutshell, anything below 37 will be recorded as a positive result. Anything between 37 and 40 will be confirmed and be retested before being reported. Anything above 40 will not be confirmed as positive. And that is the same for saliva and nasopharyngeal.
Great, thanks. I'm not sure if everybody understands this business about cycles. Can you just explain briefly how it all works?
Yes, ooh, science. So when we did the PCR test, PCR actually stands for polymerase chain reaction. And essentially it's almost like taking something and splitting it in half, right? So you start with one, you split it into two, and then those two can become four, and then those four become eight, and it keeps going like that. So if you start with one copy of the DNA, after each cycle, quote unquote, which is essentially changing the temperature 3 times to allow for it to be copied, you get double what you started with. And so the standard for the COVID PCR testing, or PCR testing in general, really is between 40 and 45 cycles. And so that's what we use. So essentially the threshold is, at what point is there enough copies of the virus to say there is COVID-19 virus in this sample? That's where the threshold comes in.
Okay, thank you. What will be done with the child's sample after testing?
Yes, this is a very, very common question. We throw away all samples after they give us a result. We do not have enough space in our fridge, in the lab, or freezer to store more than around 2,000 samples. So when we had those really huge testing days that had above 2,000 samples, we were actually throwing away samples that came earlier in the day so that we can make more space for samples that came later in the day. What actually happens is we take all the samples and throw them into a biohazard bag that gets collected from the lab by environmental health twice a week. And those samples go to the hospital to be incinerated.
Somebody wants to know, why aren't masks required for P3 students?
Why aren't there masks for P3 students?
I think they are required, aren't they?
No, they are not required for P3 students, as the mask at the primary level required at specific times, likewise at the preschool. That question came up while schools were out on remote learning. There were concerns raised about the fact that there were some positive cases in our primary schools. So we did reach out to the Department of Health, who did share with us the research and practice as it relates to students who are in that primary school range. And so the research does not support students at the primary level wearing masks all day throughout the day, but they do wear their mask at certain times.
Okay, and I think what will happen to a class that has a positive contact?
So the current process is that if we detect a positive saliva from our screening, I will report that to the Ministry of Health, letting them know exactly what class and what school it involves. That student will be contacted by the Ministry of Health or by their GP, and that's why we ask for the GP details, and they will be able to share that information with them. At the same time, we want it to be as close as possible that once the person finds out that the school is also notified, so the Ministry of Health will inform the Ministry of Education in regards to public schools so that they are aware of the positive case. As is with any other positive case, that student will be contact traced. In the meantime, they will, as has been stated earlier, receive a nasopharyngeal sample to confirm that this is definitely going to be recorded as positive. But the actual actions that the Ministry of Health takes starts from the saliva in terms of the isolation or the quarantine, because we don't want to wait a day or two and then realize that they're actually positive and then actually infected others. So the saliva positive will trigger public health action where that child will be taken out of school. Once the nasopharyngeal sample has confirmed, then that is when the further actions will be taken, will be reported locally and internationally, and then the contact tracing will begin. I think the big difference from the first outbreak last December to this outbreak now, and even to as we speak right now, is that the bubble system has been improved. And the idea is that we're doing the screening regularly so that we can say last week no one in this class had anything, but obviously this week someone does. So that gives us a bit more confidence that it's only been within the last 7 days, as opposed to not sure when the virus entered in the first place. So hopefully that answers that.
When are we looking to start?
We're looking to start as soon as possible, really.
Yes, I had that conversation with Commissioner Richards, and she will inform when we're going to start once she gets all permission slips and logistics from the schools.
But I can say for private schools, they actually started yesterday. So we started testing, I can't remember which level of Work Academy, but we tested Work Academy yesterday and that went very smoothly. So we are progressing with private schools and hopefully we can start with public schools as soon as possible.
And can you speak to the the numbers of public school students testing during the past week?
Yes, so we, as you know, we had the screening from, I think Wednesday, we kind of pushed it so that it wasn't too far out. So Wednesday, Thursday, Friday, and Saturday, either at the Pioneers Wharf Star of India or at St. Paul's. Overall, and I want to say this was a combination of students, teachers, and parents or family relatives. Overall, we got around 1,500 saliva samples, which I think was great. Obviously, it wasn't the total amount we wanted more than that. And we did actually catch a student who was confirmed to be positive on the nasopharyngeal afterwards. And we also caught a parent of a student who was positive. So it definitely was a worthwhile exercise.
Thank you. So, questions in the chat. What's the ratio of false positive tests? So well done.
I get a lot as well. The way that a positive is identified is I actually have to make the call on each and every result. There are measures in place to prevent a false positive from occurring. The only way that a false positive result can actually come about is if a sample that is positive contaminates others around it. And so there are about 4 measures in place that are intricate into the design of how we conduct the test that will allow us to prevent that cross contamination from happening, as well as allow us to identify if it has happened. I can confirm as well that when the results do come out, if I see, for example, two positive results right next to each other, and I suspect there has been some cross-contamination, I will order the lab to retest the one that I'm not sure of before it gets reported. So there is all this confirmation, and we make sure that we do as much as we can to avoid any cross contamination in how we do the test. So I would be as bold to say that we have no false positives. I can also say that in the initial, I guess up to December before the first outbreak, we were sending all of our positive samples down to the CARFA lab, and they were confirming everyone. So we have yet to have any false positives from that perspective.
Is there a possibility that the saliva tests can be made mandatory in order to keep everybody safe? It is vital for everybody to come on board and testing. I know you've addressed that already, Mrs. Richards, but can we talk about why, you know, I mean, why again we're having it voluntary and not mandatory?
Well, I think it's in its early stages, so we're just in the process of implementing a new program, a new saliva testing program. And so we have to determine, there's a legal aspect to it. So there has to be a determination whether we can legally require students or parents to have their children tested. And so that has to be explored. I think what parents need to understand, they do have an option at this point. If there is a student in a class if there's an individual who tests positive in a class and your child is in that class, then you don't have an option around your child being tested. So you just want to make sure you understand that. But right now it's by consent until further notice as we explore, the logistics, the legal logistics around this.
Okay, now somebody here is concerned about accuracy. They say they learned about a family who had a positive case. The other members tested negative. How can we trust the testing results if the other members of the family presented symptoms? The kids had the mouth test.
I think I missed some of that
Yeah, Mr.
question.
Johnson, can you speak up just a little, please?
Sorry, somebody's got their mic on and there's a lot of noise in the background. I can't see who that is. Can everybody make sure their mics are muted unless you want to give a speech or something? Thank you. So the question is, this person is given an anecdotal case. That she heard about a family who had a positive case.
I think it's Tariq Mike.
Mr. D, okay, thank you, Mr. B and Darrell.
How can we, positive case, but the other members tested negative? And he goes, how can we trust the testing results if the other members of the family presented symptoms? The kids had the mouth test and the adults a nasal test.
So I can say the sensitivity of the test is very good. It's the same test that we've been using all this time from last April. It isn't uncommon to have someone who has certain symptoms of COVID to test negative. We test a lot of people every day who have certain symptoms, and it's not COVID. It's something else. It could be the flu or whatever else it could be. As far as the one person in the household testing positive and it not being passed on, that's also not uncommon. Not everyone who has the virus passes it on to others. It depends on their interaction. I do know that it also does seem to matter if you are symptomatic or not. Usually those who are symptomatic have a lot more virus in their system, and that corresponds to having a lower CP value, and they are usually more infectious and give it to others more readily. You will find those who are asymptomatic who sometimes have a higher CP value, so in the 30s, that don't have as much virus in their system and they can't really infect others. So it really depends on the type of infection that person had, also how much virus or the viral load that that person has. In this outbreak, we have seen that a lot more people have given it to others because of the variant, the UK variant. It seems to travel a bit faster, but it wasn't everyone. So that's not an uncommon observation. Um, that's probably one of the good things about doing the testing. We can actually see who has given to others and then make the proper action on what should be done in terms of quarantining and isolation.
Great. So are there, I guess they're probably asking about false negatives. Is there any such thing as a false negative?
Oh yes, there's definitely a false negative. I mean, there's a false negative and a false positive, but they occur in different ways. On every test result, actually, if anyone here has gotten one, there is like a blurb underneath the type of test that tells you the different ways that a false negative can occur. It could be that the sample was not collected in the proper way, so the sampling could not be correct. It could be that the sample was transported incorrectly because the samples should be on ice, and if they get too hot, the viral genetic material can actually degrade and go away. It could be that whichever target we are looking at, and we look at the E gene in the virus, it could be that there's been a mutation there that we're not picking it up anymore. It could be that we've tested too early. You could have caught them when they are infected, but just not have enough virus to be picked up. So that's all actually on the official records. Whenever you get a negative result that explains we haven't detected anything at this moment, but that doesn't mean that you haven't been exposed and that you cannot become positive later.
But the fact that we're testing 25% should help to sort of mitigate some of those variables, correct?
Yes, I mean the other option is to test everyone every week, but I think that's overkill. We don't want to be doing that too much. Um, this way, we're at least testing the classroom regularly, and if there is any transmission, we should be able to pick it up.
So the next question, is it financially or logistically prohibitive to test everybody in the school system?
Overall, no. That's why we're taking this on. I think initially when it was mentioned as an idea, I did get some weird looks because it did seem like a big task. But overall, it's the way I was explained it from a financial standpoint is it's actually cheaper to pay for everyone in the school system to be tested regularly than to shut down schools and shut down the economy because of the spread. So that is the position of the government. We would rather make sure everyone's safe than to allow it to spread as it did. To be very frank, if you look back at the data, it was really the school system or the school children that were a catalyst in this outbreak. And that's because we weren't checking them, right? And we kind of hadn't really thought they could be these super spreaders, but they were. The outbreak was fueled by that. It really went from one level to the next through the schools. And so we want to make sure that that doesn't ever happen again.
Okay, thank you. How are the results going to be handled in terms of privacy when schools will be informed about a positive result?
So the positive result is not given to the school as this child is positive. That's not what is told to them. They will be informed that you may have a positive case in your school, but it's down to the parent actually to let the school know who it is. Even when there's contact tracing at the moment, people who are contacts of a positive case are not told who the positive case is. So it is possible to keep confidentiality, but still allow those who may have been in contact to be contacted to make sure that they are safe. So when you are a close contact, they say you have been in close contact with somebody. They don't give you the name and they don't necessarily even tell you where. They then let you know that you have been in close contact and what your next steps are.
And I can confirm that's the same for the department. We may be given the name of a school and say there's a positive case. We have never been given the name of any student or any adult.
Okay, somebody here says their daughter suffers from really bad asthma. He's not comfortable sending her back to school. Why wouldn't remote learning be an option?
If there is a doctor's certificate indicating that the student is extremely clinically vulnerable, then remote learning would be provided. I would recommend that the parent seek guidance from your GP or physician.
Great. Will parents be notified that their child has been selected for testing that week?
That is definitely something that can be done. In the system, when someone has a booking, there is a notification email that can be sent. And so I think that actually would be useful, because what we found today from the testing we did yesterday, the parents were getting results and saying, "Oh, I never even got tested," and then I'm saying, "This is for a child," and they're like, "Oh yeah, this probably is for my child." So we're seeing, we're kind of seeing the kinks at the minute, and we're going to iron that out. I think once we make the bookings in the system, which has to be done on a regular basis each week before the paperwork is created, we can then make sure that from the system, those notification emails are sent out so that confirmation, your daughter is getting a test tomorrow, or your son's getting a test tomorrow.
Okay.
Mr. Johnson, I have a question that was sent to me, and that's around the research with the mask and the appropriateness for, whether it's appropriate or not for students who are at those primary years to wear masks, and a question around, sharing the research with parents. I can certainly reach out to health, and we can send something out in the Scoop newsletter.
Great. How will the school ensure that children have not eaten, etc., half an hour before testing?
So the way that we did that before was try to make the testing right before a break, right? That's probably the best way to guarantee it. So before recess or before lunch, or half an hour after lunch is finished, or half an hour after recess is finished. So that, that's probably the benefit of the school setting, is that everyone goes to eat and drink at the same time, and everyone should be finished at the same time. So as long as we make it half an hour afterwards, we should be okay. And that's the same system we used in the end of the school period prior to the Easter break, and it worked quite well.
Okay.
And to just piggyback on that, what happened was meant if it interrupted, say, like a recess break, most schools just tweak the schedule just for that time period to make sure that they still had their recess and their lunch at appropriate time.
If there are insufficient, then when will the consent forms be ready, Mrs. Richards, for the parents?
We will be finalizing them between this evening and tomorrow, and then schools will need to send them out. Right now, we're looking at, and we can take some feedback, we had an option between a paper consent form that was developed, but we're looking at an online form for parents to fill out, where they'll just input the information, indicate yes or no whether you give consent. Once you go click, it goes into a spreadsheet for the school, and then the school has an indication of who has or which students do or do not have consent, and then that data will be submitted to MDL, to the lab.
Great. If there are insufficient consents for a year level, would that result in students who have consented being over-tested more than once a month?
No, not at all. We will only test the child once a month. We're hoping that we don't have that situation. So far, we've had from other schools around between 80 and 90% of parents consenting and staff. And so we're hoping for the same in the public school system. But it doesn't mean that we have to overcompensate by testing others more. In the rest home testing that we do, there are some residents whose caregivers didn't give consent, and there are some staff who don't get tested, but we don't try to compensate for that. We're not trying to hit a target here. We're just trying to make sure that those who are there are safe and that we are screening them.
So if you get 20%, would that still be considered a good representation?
It wouldn't, but let's hope we don't have that situation. This is why we're having these town halls, so that we can make it clear on what we're doing so that we get as much buy-in as possible. As one of the other parents said earlier, this is for the safety. This is something that everyone should hopefully buy into. It's a safe, non-invasive way that we can test the children. A lot of them actually enjoy it. They seem to like this thing that they can spit into, and they feel like they've accomplished something when they hit the line. And the samples are, discarded. We're not keeping them for some secret DNA database. That's not happening. So it's just our way to try to make sure that the schools can operate safely. So we're hoping that we get as much buy-in as possible from you as parents so that we can make this beneficial for everyone involved.
Awesome. Okay. With school, I'm going to ask this question because it's an important one. With school ending in just over a month, will the saliva testing extend to summer camps, keeping in mind that many kids switch between camps on a weekly basis? Is there a plan to do this throughout the summer season?
I think Tariq can take that one.
So that conversation is still in discussion because similar to the e-camps that happened while basically we were all staying at home, that we're looking at possibly testing the government camps on a weekly basis, similar to how we did the e-camps, just to make sure everyone is safe going back into camp the following week. It's not going to be a big task, say like testing the school system, because it's not as much children that go to government camps. If private camps are willing to sign up for it, well, that will probably be on them if they would like to get their staff tested or even the students tested so they can at least keep their children in camps on a regular basis and throughout the entire summer.
Great. So Dr. Weldon you might want to say a few words about the vaccinations now, or is
Yes,
there
I
any?
can.
Yeah.
Especially with the news yesterday. I think this year level primary, it may not affect as much, but it may be some of your the siblings of those in primary school. At the moment, the vaccination program obviously has proceeded, and we have a good number of adults that are vaccinated. Um, what we found in this outbreak, it just firsthand real raw data that those who were vaccinated, although yes, some of them did test positive, which is not uncommon, most of them did not pass on the virus to others, and that was the key. So we had this virus kind of running rampant all over the place. And when it got to someone who was fully immunized or even had one dose of the virus, it seems like it kind of slowed them down. And so that is really encouraging because I don't think we would have gotten through this outbreak this quickly if we didn't have the growing number of adults who were immunized. As we know, it, like I said earlier, it started in the schools, but the children then passed it on to their parents and to adults, and then it just went further. Um, Now with the FDA authorizing the vaccine for 12 to 15-year-olds, it was already approved for 16 and over, authorized for 16 and over. This is now offering a bit more protection. I think there is a government link to register interest if you would like to have the 12 to 15-year-olds vaccinated so they can gauge how much stock they need to get. But having that in the mix now gives us a bit more comfort, I'd say, because now, if it does enter, there's going to be a stop sign that says, look, you can't go any further. Whereas prior to this, there wasn't anything. If it got into the school children, we just had no defense. So I would say it has proven itself. Even with the UK variant, it seems to have done a great job at stopping, obviously, hospitalizations, which I think was reported yesterday by the hospital, but also passing on the virus to others. And so as an adult who interacts with children, I think that is something that most of them should be considering. I know that we don't have the data, but I do know there are some teachers that have been vaccinated. I have relatives who are teachers who have gotten vaccinated for that reason, because they want to make sure that they are, providing a safe environment for the children.
Great. And there's some more questions that just come in. During the last outbreak, a lot of nurseries were affected. Are we considering nurseries as well?
Oh, yes. Yeah, that seems to be ongoing as well. I had never never even thought about them prior to this, to be honest. You just didn't calculate them in, but they definitely were affected. Again, mainly because they are siblings of school children. That's kind of how it got in. The nurseries is a bit of a different conversation there because they are younger, and obviously spitting for them is a bit more difficult. But the good thing is that there's not as many of them, so it becomes a bit easier logistically. So that conversation is happening. We're looking to provide something, a solution for them as well, so that they can continue to carry on and be safe. Do private camps sign up and have staff and students tested? I'm not aware of how the private camps operate, but I do know the public camp, specifically the one that's running at the moment or was running for the essential workers. All of the staff had to be tested on the Friday in order to work on the Monday. And we caught a few staff that way who were not able to start on the Monday because they were positive. So that also proved quite effective.
And cross-contamination, what are the chances of cross-contamination since students from different classes are being tested by the same staff?
So very little chances of that, mainly because of all of the PPE that is worn by the staff. All of the Saliva team who Tariq bin Darrow is in charge of, when they come, they have on the full everything. They have on the gowns, they have on masks, they have on a screen, they have on gloves. And so there is no contamination from them to the students. We also get any staff members from the school who are assisting to also be gowned down in full PPE. And so in that way, it becomes similar to the testing sites that are operating, who are also seeing many people. I don't think to date we have had any cross-contamination from a testing site. And so we're pretty confident that there won't be any in this setting as well.
And we also, just to reassure that person who asked the question, between each person being tested, we actually sanitize the entire area. So we have desanitizing wipes where we're able to wipe down and sanitize anyone. We're able to. Sorry about that. We're able to sanitize each area between each person coming to get tested. So we make sure that everything is clean, sanitized, and everyone's wearing full PPE to avoid the any form of cross contamination or any passing on of the infection from a person to the tester.
And the last thing is that all of my staff, both the Saliva team and the lab team, we get tested regularly. So, they have access to these Saliva kits, so we make them do it on a regular basis as well, to just make sure that they are not incubating the virus.